Good morning, everyone. Today, what I'd like to do is talk about what your treatment plan would be looking like with regards to fusions in the foot. And there are many different joints in the foot that we particularly, as foot and ankle surgeons and orthopedists, will fuse. And we do this for a couple of reasons. Number one, we do this because of joint stiffness and arthritis. So as we age up or as time progresses, our joints might not be lined up perfectly, and thus they wear in an uneven pattern. And this can cause the cartilage to actually break down, and it can cause spurs and thus pain. And so we will essentially eliminate this joint or fuse it together to help prevent pain and to basically better your comfort with any sort of walking. The other reason that we'll actually fuse a joint is if it is too loose. Now, what do you say, Maskill, what are you talking about with regards to that? Well, when it's too loose, we call that hypermobile. And when somebody is hypermobile, that means that their joint is so loose that it's not held within the constraints of that particular joint. And then what ends up happening is you can see a deformity then occur in the foot. And there are really some key areas where if the patient does have some laxity or does have some looseness or hypermobility, we can see the foot completely collapse into a flat position or just essentially cause pain because that particular bone isn't doing its job that it should. So to relieve you of that pain, we will actually stiffen up the joint to help accommodate for the looser ligaments that patients may be plagued with. And so I want to kind of discuss this with you and discuss a little bit of the anatomy and what we actually do to fuse so that you kind of understand that. And then let's talk about your post-operative treatment plan and protocol afterwards. So I have a model here today, and just so that you can kind of understand what we're doing here, each one of these individual intersections between all of these bones here, these are the joints. And so when somebody gets stiff, it's very, very hard to move. And when somebody is hypermobile or lax, it's very, very easy to move. So for example, this particular bone here, I call this the kickstand to the foot. This is the first metatarsal. And this particular joint very frequently wants to be a thumb, and it wants to really be loose like this. And in certain patients, especially with certain genetics, these particular ligaments here can get very, very loose, and this becomes very wobbly. And so what can happen? Basically, you can end up with a bunion where this toe drifts out and this particular side of that bone starts to get very prominent in your shoe, or we can see that kickstand start to fail and the foot starts to fall in because the kickstand is partially up. And as we know, if you leave a bike kickstand halfway up, the bike tips over. So we want to add some stiffness to add some integrity to your foot so that it doesn't fall over like that. There are other various joints that we will fuse along the way to help with deformity correction in particular, or just to get rid of some of the pain that you have because these spurs are making it very uncomfortable. And so when we do that, what we're doing is actually bolting some bones together and eliminating the space in between each of the bones and asking them to fuse into one bone piece. That is what we call a fusion. When we talk about fusions, what does that look like? A fusion is typically done in the operating room, and a lot of times we are doing multiple fusions, multiple bones at one time. And this is all dependent on the particular deformity that you have or the pain location that you have. And we would be talking about this in the office as far as what joints in particular we would want to fuse. The good thing is that a lot of times in the foot, most of the time actually, the fusion actually does not necessarily affect how you walk. Occasionally, especially in the rear foot joints back by the ankle, those can cause some uncertainty on uneven ground because they do allow for some balance. But in the midfoot area, those particular bones do very well. And those particular joints don't actually affect your gait really at all. We call those non-essential joints. So we're really fusing non-essential and essential joints at times to help correct that deformity, again, so that you can walk. And we'll discuss how these particular fusions are going to affect your gait in that office visit. So what do we do in surgery? In surgery, what we do is we make an incision directly over that joint, and we go and we prepare the surfaces of the joint. And what that means is we get rid of the spurs that are really in the way and causing any sort of pain. We get rid of the scar tissue that's actually causing some of the pain as well. And then what we do is we actually make a bunch of holes in both sides of the joint. And what this does is it lets the blood flow in between the two bony surfaces. And that really brings in excellent cells that help to create bone. That's my job in the OR, so you don't have to worry about that. After we do that, then we will oftentimes place either bone graft from bone that we've collected from your surgery. We'll reuse it and recycle it. Or sometimes we use a cadaver piece that we can actually put inside there, and this will actually augment your fusion. So we will put some factors in there that can actually help you grow bone, thus improving your prognosis with regards to healing this. Once we get that joint all set and prepared, then what we do is we fixate it. And each joint and each particular patient has its own recipe for fixation. And what I mean by fixation is screws and plates. So what we will do is we will put some screws that traverse across the joint. Sometimes we use plates and put the screws outside of the joint, but we get to squeeze it down that way. But ultimately, we want to add some compression, and we want to make sure that those bony surfaces line up really well so that we get the overall correction that we want. After surgery, we end up putting you into a big splint. And this splint is really important because it's going to go from your foot all the way up to your lower calf. And it's to keep your ankle in that perfect position. So we want it nice and at 90 degrees so that when you come out of your splint, then your foot sits nicely on the ground. People always ask, do I have to wear the splint? Do I have to do that? And the answer is yes. We really want you to do that because it keeps your Achilles nice and out to length so that your foot will be flat on the ground. As we lay and watch TV and sleep, etc., if we don't have that splint on, then your foot will naturally tilt down and your ankle kind of points a little bit. And that's totally fine for it to happen. But when you're not having had surgery, it's no problem because you get up and walk and it's not an issue. But when you've had surgery and you aren't walking for a period of time, that's when your Achilles can get tight. So we really put you in that splint to make sure that that Achilles is protected so that you can easily transition out of your splint into a regular shoe. So you're going to come out of that surgery with a splint. And we're also going to give you pain medication. And this pain medication is also going to be done in conjunction with a block. And from a block standpoint, we actually numb you from the knee down, and you get excellent pain relief with this. However, it does wear off, and it usually lasts for about 24 to 48 hours. And so what we ask during that initial time is that you take the pain medication that we give you around the clock, even when you have no pain. Because then what ends up happening is the block will wear off, and you really want those pain meds already in your system, because it will really make that transition much nicer and smoother and more tolerable for you. If you don't have them in your system, then you run the risk of being always behind your pain, and the pain control is just not as effective as if it's already done at the beginning. So once you can actually feel your foot after the numbness is kind of worn off from that block, and you can feel the aching, then you can taper back on your pain medication appropriately, and you can get off your pain medication as you see fit. So we're going to keep you non-weight bearing after the surgery as well. And so what this means, you're going to be having this splint on, and this splint, remember, is very sterile. And so we don't actually have you do anything to it. We just want you to elevate your foot, because this is going to decrease the swelling. And during the first couple of weeks, swelling is a big deal. We don't want those incisions to be forced open like this at all. We want them to be nice and under the least amount of stress and tension that we can possibly get. So you're going to have the splint, and you're going to be made non-weight bearing. And what I mean by non-weight bearing is we don't want you to put any weight on it. You may rest it on the ground, no problem. And you may stand on your unaffected leg and rest this one on the ground even when you're standing, but we don't want you putting any pressure on it. I always say our screws are good, but they're not that good. The pressure in these areas is so great when you walk that you can actually break the screws, break the plates, or disrupt any healing that you've had to that point. So we want to make sure to be careful with regards to that. So after the surgery, you'll be in your splint. You're going to be non-weight bearing, so we're going to help you with crutches. If we need a walker, we can do that too. Or a knee scooter is very nice as well, because you can kneel on it and you can scoot and remain non-weight bearing as much as possible. If you need any of these, please reach out to my nurse, and she can make sure that you're provided with scripts for all of these. You stay in that splint then for about 2 weeks. And during that time, you're going to have some swelling, you're going to have some redness and purpleness of your toes, and maybe some numbness and tingling. If you have any numbness or tingling, that is from us moving and displacing those nerves, which can be common immediately after surgery. And if it's really bothersome, please call us, because there's a medication that we can give that can help quiet those nerves down a little bit for you and make it a little bit more comfortable for you. They're very effective with regards to that. But otherwise, we'll see you in 2 weeks. At the 2-week office visit, we're going to get an x-ray that shows us that everything has stayed where we wanted it to stay over the last couple of weeks. And then we're also going to evaluate your foot to see if we can take out the sutures. The foot, as we look at it, we really want it to be with as little swelling as possible. And so sometimes you'll see us delay the actual removal of your sutures, maybe a week, maybe 2 weeks. We have up until 4 weeks to really take those sutures out. And everybody swells a little bit differently. So we hope to be able to take them out at 2 weeks, but we might, for your safety, delay it maybe a week. And that's going to let that skin mature so that we don't have any what we call wound dehiscences, where the wound opens up when it gets stressed by the swelling. So we're going to do a wound check and get an x-ray, and then you're going to be placed into a boot. This is an example of a boot that you will be wearing, and these are usually relatively comfortable for patients. Patients do really well with this. And again, this is going to be in exchange for the splint that we put you on immediately after surgery. And again, you can see here, this is going to keep your Achilles nice and out to length so that we don't have any feet that drop down. We don't want anyone to have tightness of that Achilles, because it's going to make it much more difficult to walk. And keeping this tension appropriately here is going to also cause the least amount of pain in your foot when you initially start walking, because the pressure won't be as great. So we really want you to keep this boot on as much as possible. We also would like you to use this. It's got some bladders in there that can inflate around your leg. We would love for you to actually, to the point of comfort, inflate the actual bladders in these boots so that it really grips your calf. This helps reduce the amount of motion inside the boot so that your foot stays nice and still. And it also helps with comfort so that you're not rattling around in here. We're gonna treat you in the boot for approximately 6 more weeks. And then we're gonna bring you back to the office to do an 8-week office visit. And at that office visit, we're going to hopefully let you walk at that visit. About 95% of patients are gonna start walking at the 8-week office visit. So this is about 2 months after surgery. And at that visit, we're going to, again, look at your incisions, look at your swelling, and make sure that everything is coming along well with regards to that. We're going to get an x-ray of your foot or of your ankle, etc., whichever is involved in the actual procedure, and check on how you're healing and what the position of your hardware is inside your foot. After we verify that everything is looking great and feeling nice and solid, we're going to then recommend that you start walking. Occasionally, patients need a little bit more time, and this might be due to the fact that we're doing a revision. A lot of revision work needs extra time, in which case we'll ask you to stay off it for yet another month. But most of the patients are going to be allowed to walk immediately at the 8-week point. So after we get your x-ray and verify that everything is healed, we're going to advance your weight bearing, and then what we're going to do is expect you to walk on this. And the hard thing about this is that it's not going to be easy. There's going to be pain associated with this. You haven't walked on it for a couple of months, so there's going to be some discomfort for sure. And what we want you to do is walk through some of that pain. Initially, we actually have you utilize your boot. And this really helps when that boot grips your calf. It actually allows some of the weight to be transferred or borne through your calf, which actually then protects your foot. So it's a little bit more comfortable for patients rather than going directly into a shoe. But if it's more comfortable to go into a shoe, we encourage you to do that as well. We don't want you to be painful during this time. We want to make this as comfortable as possible. So the boot at this point, now that we're 2 months out, is no longer required. It's used for comfort. And so we want you to start putting some weight on it. Initially, I have patients use a cane or a crutch, kind of like a cane, just to help unload some of that weight from their foot. And then gradually, and a lot of times we add physical therapy if the patient would like. We can give you some instruction on that as well, but they're going to help you walk and get your balance back and gradually put more and more weight on it. After about 1 month of walking on it, so now this is at the 3-month point, we would really love it that if you're still in that boot by then, that you have transitioned then to a shoe. And again, this just gives you that goal to go for. And so we really want you to start walking then in a regular shoe. And then I see you at the 4-month point, at which time I want to watch how you walk. I want to see how that foot looks like. I want to see the deformity correction. And we'll also get a new x-ray. And at that point, we'll evaluate the healing of the bone and how that hardware looks. At that point, also at that 4-month visit, I would love to see you with no boot, in a regular shoe rather, and with as little of a limp as possible. A lot of times the limp, if we're not careful, ends up becoming a habit. And so what we want to do is I want to just make sure that you're walking well and that limp is erased as much as possible. Usually at 4 months, patients are still achy, They definitely have painful spots. It's not a perfect foot. And they're kind of getting over this whole 4-month period of healing, and they're getting anxious for this foot to feel better. And I'm here to tell you that your biggest improvement in healing is during this next phase, between the 4 and the 7-month point. So in this interval between 4 months and 7 months, this is really now where your activity is really increasing significantly. You're out of your boot, you're in a shoe, and provided everything is looking good, we're letting you start to get back to sport, starting to get back to activities that you love. And so really things start turning a corner for you, especially mentally as well. It's just, you finally feel like, ooh, things are going the way that I want them to go. And so I see you at the 7-month point. So this is 3 months later. And again, if we've had to do any tweaking with your gait or your walk, we will use physical therapy during that period. But at that 7-month visit, we want to get another x-ray, again, just to check on the maturation of your fusion, making sure that your hardware is intact and making sure that that deformity is still looking corrected. And then usually if everything is looking good at that point in time, we can go ahead and discharge you provided everything looks good. Otherwise, we'll make recommendations accordingly depending on how things are looking. So what kind of complications should patients be nervous about with regards to doing any sort of fusion? Well, the most commonly known complications associated with this are going to be infection. Anytime you make an incision, you are at risk for infection, especially until that skin heals. So again, we want to make sure that swelling is down. And if you have any fevers, chills, nausea, or vomiting at all with regards to this, we really want you to be able to give us a call and we can help you out with any sort of medication that we may deem appropriate. Thank goodness that our infection rate is very low, and we are typically looking at about less than 1% of an infection rate. So these are pretty rare. If anything, as far as complications are concerned, we might notice that maybe one of your wound has opened up just a little bit from the swelling. No problem. We can go ahead and take care of that with some local wound care, and usually these are not an issue. But it would be nice if you let us know if there's any discomfort that we can help you with. We can check all of that. So the other complications would be some numbness and tingling in the foot. And this occurs specifically in certain areas when we really have to move those nerves. And so we just ask that if you do suffer from any numbness or tingling and it bothers you, please let us know, and there's medication that we can again give you that can really help quiet these nerves down a little bit and make things more comfortable for you. Usually these are temporary, just from us moving them, but occasionally on the small nerves we do cut them just because we have to create a window for ourselves. And so there can be some numbness and tingling that are most notably around your incisions and can involve other areas of the foot just from having moved the nerve, but again, these are much more rare. The other thing that can occur is that the fusion could not take. In other words, you end up with what we call a non-union, where the bone ends don't unite. And this can be very frustrating. And some of the symptoms that we see with this are persistent swelling and pain right over the area. And we really see this especially if patients haven't been compliant, but even patients that have been following everything to the letter can still get a non-union. We see this in about 10% of patients nationwide. Our fusion rate is actually much higher than the national average. We're looking at about a 95 to 96% fusion rate, especially with most of the joints in the foot. There are a couple joints that don't have as high of a union rate, but they're all still very much up in the 90s. But as we work through this and get our x-rays, we will be checking for this as well. There are certain instances that we can leave a non-union alone, and we don't have to do anything. This is primarily when you're comfortable and you're not having any pain. We just recommend watching the x-rays for a little bit of time to make sure that nothing changes. But if it is uncomfortable and we've tried everything, then what we do is we make a recommendation to redo the procedure, which nobody wants to hear. But again, at least there's a solution to the problem. Your biggest risk with this whole thing is probably that some of the hardware that we put into that fusion area might irritate you. And this is something that is very easily addressed, but it is addressed with a surgery that usually occurs at about the 6 to 7 month point. This is the first time that we would consider doing something like that because we want that fusion site to mature. And so what we do at that point, if you're still having some pain, is we would order a CAT scan. And a CAT scan is going to be better than an x-ray, and it's going to really help us evaluate the interior of that joint well. And provided that is all healed, you don't need the hardware in there anymore. So if the hardware is really bothering you, we can take it out. And the nice thing about that second surgery for hardware removal is that provided that's all that we're doing at that point in time, we just make an incision right over that same area, take out your screws or your plate, whatever you would have in there. We give them to you in a little baggie as you leave, and you get to walk on your foot that very same day. So it's a much different recovery than immediately after your fusion. And so we hope that you can utilize this and help with your expectations, setting them appropriately, and just being able to see exactly what is going to be happening during your course post-operatively after you've had your fusion.